Just just a couple to do, Carrie. And then are you all worked out logistically? I think we have Evan down to go first, and then Mustafa. Is that okay? And if you have slides, do you want to share your own screen, or we good to go on that, or we need to just deal with any logistics quickly?
Sounds like we're in good shape. We've got very resourceful, independent humans.
That's what we that's what we like.
We do.
Well, maybe we'll wait just a minute. I'll fill in the time for other people to see who's joining. But as you're all aware and saw Justin's reminder this morning, we're continuing today on our skilled nursing care and meets implementation science intersection discussions. Looks like a couple of fun different topics to do, and I will let Carrie facilitate in a moment here. The only thing I do want to point out is a reminder about upcoming sessions. The first one is no session next week, so that's time for you all to work on your own projects and things. On the 19th, we're doing something a little different that I thought I would just explain briefly, because it may not be apparent to everybody from the announcement and the jargon. The IPCC AR6 summary policy that Brian Ford is going to join us for is the report from the UN Intergovernmental Panel on Climate Change. And particularly, it's their most recent recommendations. How that's relevant, you might think about, is they have a pretty cool, as part of this, an interactive atlas, a geospatial atlas that Brian is going to illustrate to us. And it brings up the more general issue of, I think, geospatial information, and applies especially with an environmental focus. But that's the topic. I think it's something different, but could be kind of cool. And I do think, fairly sure, it's one future direction for implementation science. I know there was a recent meeting that the National Institute for Environmental Health Sciences held on implementation science. So I think it's just something we might want to keep on our radar screen, and encourage you all to come to that. And if you have it in front of you, you might see we still need one more presenter for the 19th. So don't be bashful about that also. And with that, then I will turn it back to you then, Carrie.
Great. Thank you so much, Russ. And thank you for all of you who are joining today. We're so grateful for this opportunity to present in this forum our DISCO, what we call DISCO, D&I Science in the Care of Older Adults. So we like our acronyms and our fun things that we do. And we are really looking forward to these two presentations today. So the first is Evan Plys, who's going to do a presentation called Building Resilience in Skilled Nursing Facilities, or BRISK, right? Another great acronym. Development and pilot testing of a dyadic intervention for psychological distress in post-acute skilled nursing care. And then Mustafa is going to go after that and present on Nursing Homes Patient Safety Learning Lab, or NuHoPS L2. So we'll look forward to both of these. And without further ado, I will let Evan go. And just as a reminder, what we like to do is have a couple of very specific questions for our implementation science experts here. And if you don't do that, Russ will force you into it at some point along the way. So be prepared for that. All right, Evan, I'll let you take it away.
Thank you. I will try to follow the rules here. So I am going to share my screen. Just let me know that everyone can see this okay.
Looks good. It's in view mode.
I remember how to do this. There we go.
There you go. Perfect.
Well, thank you so much for the opportunity to present this and get feedback from this esteemed group. So I'm Evan Plys. I'm an assistant professor in the psychiatry department, and I'm a clinical geropsychologist here at CU. So I'm going to be presenting what is my K-23 application to the National Institute on Aging. So where I am right now in this process is I've submitted this last October. It was scored. It's above the pay line. This is not an ADRD specific submission. If you're familiar with NIA, there's quite a differential there in the pay line. And so I am preparing a resubmission likely for July this summer. So really the biggest thing that I've been thinking about for this resubmission is a lens of health disparities and promoting health equity with this proposal. So, for myself, this is something that I'm really invested in, and it's been a thread of my work in post-acute long-term care, but I've not had training specifically on health equity. The issue is I feel like it's been a challenge to fit it into this project because I didn't write it as like this is a specific group facing a specific disparity. And so I'm having to backtrack and we'll have a couple questions related to that. So I will go through this very, very quickly. Just the background, kind of why this project. So if you think of post-acute care, so this is skilled rehabilitation. An older adult goes to a hospital, oftentimes for a fall, exacerbation of a chronic condition like COPD or heart failure, stroke, and then will discharge to a nursing home before going home to the community. Really stressful time for not only the patient, but also their caregivers. And oftentimes we think about psychological stress as siloed. So there's the patient concerns and the caregiver concerns. But particularly for this group where there are these multiple care transitions, and it's often in the context of declining health in general. I really think that looking at the dyad and kind of these shared stressors is kind of the best way to engage this group in psychological services. There's a few benefits to not only the short-term rehabilitation outcomes of providing psychological coping skills and decreasing things like depression and anxiety, but also long-term outcomes. Most notably, there is a relationship between both caregiver depression and patient depression and avoidable 30-day rehospitalizations. From a dyadic lens, when we're engaging, and when I say dyad, I mean the older patient and their caregiver. So when we're engaging them together, early intervention is really key because if you think about some of these shared stressors around navigating roles and losses and illness management, there's a lot of spillover and interdependence of this psychological stress that can confound and lead to chronic psychological distress. The last thing I will say is that I also think SNFs are a critical window for engaging folks in psychological care, because if you think of this population, there's a lot of barriers to seeking community-based care. One is transitional care is really not very good for particularly behavioral health, coordinating with community psychologists. And then also, if you think of like the amount of health issues that this population is facing, oftentimes, depression, anxiety rarely kind of goes to the top of the list, even reporting that to their PCP. So that's kind of why I want to do this type of dyadic intervention in this space of post-acute care. So originally when I wrote this proposal, I was thinking about it from kind of like a primary care perspective, like this population health of, people are coming in with similar psychological stressors. And so how do we cast a wide net? But, as I think more about how to, increase the health equity lens, I think more about this dual eligible population. So these are folks who are eligible for Medicare and Medicaid. And this is actually where I would like to see this intervention end up, and I'll talk about that in just a moment. This is a population that has higher SNF usage, higher rehospitalization, Higher healthcare spending, also greater rates of emotional distress and poor access to behavioral health services. So I really want to focus on this population, but SNFs are paid for by Medicare. So, they're not going to have a facility that is housed with, all dual eligible folks. It's going to be a mix there. So this creates a challenge for recruitment around, I'm in this setting where it's hard to recruit dyads already. And, I think the more that I add to this, inclusion criteria, the more challenging it becomes for me. So actually, let me see. Sorry, I'm skipping around. So one of my questions here is about recruitment and thinking about kind of the pros and cons of casting this wide net for, we're going to try to make it as generalizable as possible, and really have a very loose inclusion criteria, really just based off of, cognitive ability. Like, can folks participate in this, or do I, really try to narrow it down to, a very specific population, and then, in future trials, because this is a study of intervention development and piloting. So I would love some feedback about when you're in a community-based setting, and the goal is a generalizable, kind of like thinking about primary care population-based intervention. Where do you start? Do you start small and build up, or do you kind of start big and then make adjustments there? So I'd love any feedback about that.
Just to be clear, Evan, you'd like to pause and have discussion now, right? Rather
Oh,
than
yes.
Okay, just wanted to make sure whether it was a thought question or discussion. I think it would be great, if you're okay with it, to have some discussion, and then you and Carrie just watch the time, and in case we get off, cut us off so you can get back to the rest of your presentation.
Okay, perfect. Do you want me to stop sharing while we discuss, or?
That's totally up to you.
Let's do that. I think that it puts people on the hot seat. They have to.
Good. Yeah, we'll just start going down and calling on names if people don't respond. Well, let me just kick it off with a couple of thoughts. Generally, from my perspective, as implementation scientist, I'm always interested in generalization. So I think a broader sample, and my guess is, I'm assuming that someday you'd really like to get this to a very broad SNF population, not just one particular condition or group or something. So I would generally, with some modest exceptions, thinking about people who just clearly wouldn't be appropriate, or where this couldn't work for, and go for broader. The other reason to maybe do that, if it depends on your sample, but that might allow you ability to at least do some exploratory analysis of different subgroups or something, and again, the more variety you have there, the better maybe. The downside to that is it all depends on the reviewers, in my experience, and some reviewers are really going to like the simplest, the better, the cleanest, and that sort of thing. And let's just do one tiny step that isn't too ambitious. So I think it's somewhat the luck of the draw and kind of who the reviewers are. If it's more implementation science, myself, I might encourage broader. If you think it's going to be a more basic, fundamental group to review it, then maybe keep it narrower. But sorry to ramble on. What other people think?
So this is Roger. I agree with Russ's position and understand the balance, but we cannot continue to perpetuate this we can't do this, so cut a piece of it out and do a small thing that doesn't generalize. And so I agree with Russ. One of the things I wasn't clear about in the presentation, when you're thinking about measuring effectiveness of the intervention, are you thinking about symptom reduction?
Yeah, so the primary outcome would be anxiety and depression.
So without getting on a soapbox about anxiety and depression measures, in the setting that we're talking about, that you're talking about, it seems to me that overall adaptive functioning is really the target, isn't it? Improving overall functioning.
Yeah.
So I think that anxiety and depression measures, I've been dubbing around with anxiety and depression measures for 30 years. So I think they're limited in how they inform issues related to overall function. And I might encourage you to look at measures of adaptive functioning. Specifically, the work that I do is focused on quality of life. And one of the interesting things about quality of life work, if you look at John Ware's work, it's predictive of numbers of things, including morbidity and mortality, risk of an untoward medical event, patient engagement. So for what that's worth, you just might think about that.
And Roger, can you say more about that, or would you mind providing some key references in the chat if you have access to the chat, or is there?
Happy to do that.
Okay.
Happy to do that.
That would be terrific.
We're working on 2 or 3 different projects at the moment, including John Ware's quality of life work, and I'm happy to give any feedback to that. I'm just going to give you access to a website that will tell you everything you need to know about that work.
Yeah, I really appreciate that comment. And if it's okay, it kind of leads me to one of the other bigger questions that I had. And if it's okay, I'd like to actually share my screen again and see if I can talk through this. All right. Oh, sorry for anyone who has neurological concerns. Turn your screen off. Okay, so one of the other issues, I think, as your question or your comment about quality of life is alluding to, is clinical psychology is not already embedded in the SNF setting. I think that on some level, people appreciate the main stakeholders in SNFs appreciate the role of behavioral health. But it often feels like there's a difference in language and a difference in values as well. So I think that this question of like depression, anxiety, that being my primary outcome, kind of based off of just the work that exists in this space of dyadic interventions, does not really translate to the language of the main people in SNFs, the executive directors. They're going to be really driven by these CMS quality measures. And I think that, there is an argument to be made that, some of these like anxiety and depression can predict these. But when you're boiling it down to, the least costly intervention, the least invasive intervention, I want to be able to speak, their language, and say, here's how my intervention kind of fits in with your priority areas. Just, good community engaged research. But I have struggled to find that common language, and how much, and so I'd love to, tap into the resources I have available on this call around, how much of that, in the perspective of, me having my clinical psychology lens and, the SNF really having the CMS lens, how do you approach the give and take? Is it advantageous to kind of adapt, my intervention to say, I know that rehospitalizations are a really big issue. So, I'm going to have a module on, appropriate, like a decision tree or something like that, for example, versus how much do I really try to push my agenda of, these are what's important to you. Here's what I'm doing, and here's how this may or may not kind of fit into your world. If I don't know if I'm phrasing that question correct. I can say more if I'm not phrasing it in the best way.
I think you did great, Roger, again. And I think the thing that I would like to underline 4 times is you're saying to the facility something about what's important to you. I'm a clinical psychologist. I'm a health psychologist. I don't even talk about behavioral health. I think it's an error. I talk about function. I talk about multimorbidity. I talk about actionable medical activities in medical setting. And I think that a clinical psychology has suffered from being aligned with mental health as contrasted with medicine. And I think that issue that you're underlining about it's really a different lens, it's different language is crucial.
Others?
There is a comment about the average length of stay in SNF is between 20 and 38 days, although Medicare will pay up to 100. I'd like to know more about how the intervention plus the observation time period to see change in outcomes is planned for these short time frames.
Yeah, it's a great, so actually, this is a 6-session intervention, and it can continue. So it's flexible in how it, like, it doesn't have to be all the sessions during a SNF stay. So it's initiated during a SNF and it can continue after discharge. But the intervention is a 6-session, 45-minute intervention. Does that address?
Connie, does that answer your question?
I can never find the unmute button fast enough. It does, but it leads to more questions, because then, so this is a study in which you'll be collecting outcomes outside of the SNF environment if the sessions are completed or the observations are completed after the SNF stay is over. So it may be initiated in the SNF period, but it doesn't necessarily limit, which means that the patient's going back to their usual setting. Maybe it's a home or maybe it's an institution, and it's connecting back into their other sources of care, such as primary care or other. So it's becoming a little more complex, and there are more variables at play, which makes it all the more interesting from an implementation perspective. And I'll be interested in seeing. We haven't gotten to see your presentation yet, and I'm sure there's more to come, but it certainly builds my interest in terms of seeing how this is engineered or designed. So thank you. Yes, that was a good start.
And a comment, Evan, if you're not able to also look at the chat from Russ, I think the focus on stakeholder perspective and what is valued by them is right on. I always ask myself, if this is successful, what will be needed for this to be broadly adopted by other settings and sustained. So I know people want that. This is beyond what Russ is saying, but I know the focus on hospitalizations is always there. But you know, you see the person who's miserable and they really did need to be hospitalized, and that was the right thing to do. And I just always worry that if we get into that mindset of hospitalizations are bad and they're always bad, it pushes us in a uncomfortable place. And then Amy has a comment. I love the notion of other potential outcomes that SNFs may care about. I could venture a guess, but I wonder if you have had a chance to ask this to SNF leaders, clinicians, staff, or advisory groups composed of these individuals. Understanding the pains and gains for those interest groups would help. What kinds of decisions do you need to make, and what information do you need to make those decisions? Lots to noodle on there, Evan.
This is a very helpful chat. So, you know, and I think the question too about, you know, who, as I'm hearing this question about, you know, continuing on after discharge now into, I'm going to call it primary care land. It also, for me, raises this issue of like, who is, you know, as I have this intervention, who's the owner of this intervention? And I think that's also something that, you know, I haven't fully addressed in this proposal, because, and it wasn't any feedback that I got from the reviewers. I think one alluded to it, but it wasn't a specific thing that anybody mentioned. But I also recognize that, you know, I am trying to do this work of building my career of, you know, developing these types of interventions in this setting. And it is kind of unclear to me where behavioral health really fits in these settings. You know, is this something that, you know, a nursing home is going to pay for? Is this something that, you know, like a managed care company, like, you know, like a regional care collective organization is going to pay for? Or is this, you know, through, you know, probably not primary care? But I see the importance of that. And, you know, I would also appreciate kind of any feedback about at what point do I have to, you know, really address that? And I'm assuming that the answer of this group will be very early on. And at this point where I am like developing this intervention, like I am starting with qualitative interviews, stakeholder engagement to like build this intervention up. You know, how do I appreciate that question of, you know, who owns this? And I'm going to stop my screen for a second because I'd love discussion here.
Yeah, Amy, are you able to?
Yeah, I can. Evan, I wasn't quite sure as you were reflecting there, then like you do know who the owner is, or you're still not sure? That part of what you were saying, I wasn't quite following.
I'm still not sure. So kind of like who's paying for the psychologist to do this intervention? I'm not sure of that yet.
And I mean, I try to think of this in a couple levels, right? And we love to noodle on adoption at multiple levels here in this group. So there's adoption at the staff level, which I'm thinking then means the psychologist. So the psychologist is owner of whether they're willing to do this with a patient in the SNF. Am I following that piece right?
Mm-hmm, yeah.
And then adoption at a setting level would be perhaps the SNF leader or whoever employs the psychologist and how the psychologist is reimbursed, that they could carve out money or see a way for funding to support that psychologist if they were willing. So sometimes I think about it as, is there some latitude in what the psychologist can do with their time, or does it all have to be on specific funding streams? Understanding that is helpful if there's some latitude in their time, then if this is going to help improve outcomes of success for whoever funds them and the leaders of the SNF, that was where you were looking maybe at some outcome metrics of success, but also these pains and gains. But the staff themselves, the psychologists, how do they see this as really improving life for their patients, their quadruple aim, they're feeling that as a psychologist doing this work, they're seeing some value, that things that are frustrating to them maybe are improved. I'm just sort of thinking aloud here. But Bethany does lots of great work on this. That I was really just parroting her and the I-Core model with the things I put in the chat, and also thinking of it in the lens of PRISM, the RE-AIM PRISM model of the inner context and also the patients for these, what's their perspective? What's the perceived value to them?
And you did a great job with that, Amy. As you really think about what are the challenges in delivering this, in sustaining these types of models of care, what kinds of decisions are the decision makers making? And what information do they need to make those decisions? Is this something we're going to do? Is this something we're going to sustain? How will we sustain it? Does it align with our metrics for success? Does it alleviate some pain that we have? And so really thinking about how would you then articulate that back to those decision makers? How would you need to package that information? What data sources would they need to see? And what does that actually look like? And so I'm going to put the link to our paper in there, but I would also really encourage you to come to CopperCon if you haven't already. This is all you're going to hear from me for the next month and a half. And so Jonathan Pirtle is, I believe it's a Temple, I think, somewhere in Philadelphia, is coming to talk about policy dissemination to policymakers. And he is probably one of the best I've ever heard talk about how do you conceptualize outcomes for policymakers in particular, decision makers, and not just sort of big P policy, but little p policy. Thank you, Justin.
So this is Roger. I have a couple of more comments. The first is, in terms of payment, why would this not be an ideal setting to use the Medicare approved health and behavior codes? And in many cases, well, Medicare is for at least that set of patients who are Medicare covered. The second thing is implicit in your idea is that psychologists should be the people delivering the intervention. And I think that there is an emerging literature that suggests that in facilities like nursing home, if the issue is, or rehabilitation facility, if the issue is generalizability to the intervention being available, perhaps a different model, something like training nursing assistants or medical assistants to deliver the intervention under supervision of a psychologist, might be an alternative that may be more viable at the organizational level. Because if you can't sell it at the organizational level, you're not going to have access to the supports that you need to make it effective in that setting.
I was trying to type to this, but Roger, one issue I've had as I've tried to leverage Medicare behavioral health coverage for certain things, and this is in an outpatient setting, so I don't know if it would apply to SNFs at all, but is that it requires a patient copay along with it. And sometimes that copay is not as easy to identify or quantify for patients at the time we deliver it as others, or they get surprise bills and they get upset. And I've seen clinics that try to do things like that end up backing away from it because they get angry patients and that's not what they want. So I don't know if you've seen issues, ways to get around that are creative, other thoughts.
Oh, sure. It's it's a ridiculous issue, but I can only speak to the copay issue in an outpatient setting. So I've been away from rehabilitation facilities and nursing homes, so I don't know current status, but I could probably figure that out. But for joint eligible patients, patients who are income limited and for whom it's Medicare and Medicaid, there's no copay. So for a facility that winds, and for patients, that winds up being another thing to think through. It's a Medicare charge and it's a Medicaid copay.
That's a good point. And does that matter if they're in a managed plan or not? I'm probably taking us way into the weeds here, Evan, and you'll definitely want to consider if it's those are.
Given the thousands of managed plans, you know, I don't think that there's a generalizable answer.
Okay. Fair point.
But my experience is dual eligibility generally means minimal, if any, copay for behavioral intervention.
Great comments.
So Evan, maybe we should let you get back and finish your slides and then see where else we're going. Thank you, everybody, for the rich discussion. Keep it coming, but maybe let's keep it in the chat for the next few minutes. Let Evan finish his slides.
Okay, so I recognize the time, so I'm going to apologize in advance for breezing through or going through this overly briskly, you know, given the theme. So for my aims, just wanted to kind of orient to everyone to the scope of the project. This is quite small scale of really developing this intervention and just doing feasibility testing. So I think it's better displayed in this infographic here of, you know, aim one is really developing the intervention with multi-level stakeholder engagement. So we're interviewing dyads who are in the SNF, and then also engaging frontline staff to see how this might fit with workflow, how to have them adopt this type of intervention, and then also SNF leadership to address some of these questions that we're talking about, how to you know, market this to them. So then aim two is really just refining in a single arm open pilot. So just a really small number of patients and staff where I'll be collecting mixed methods data and making any refinements in the intervention. And then in aim three is the feasibility trial. So the outcomes are really feasibility, acceptability, and fidelity. So any type of clinical benefit is going to be an exploratory analysis because I am not going to be powered for that. And I am not going to, I'm going to use feasibility data for an R01 rather than try to collect effect sizes, because I believe there's kind of a debate there about whether that's actually a valid predictor of sample size for a larger trial. And this is all rooted in the NIH stage model here. So as I mentioned, this is a 6-session intervention. So there's going to be 2 general sessions that everybody will get around coping, and then 4 tailored interventions. There will be a companion website, and it'll be delivered in a hybrid design. So everything will be able to be delivered via telehealth, but ideally we'll have a couple of sessions in the SNF, and then we can transition to telehealth afterwards. And this is all modeled after the trial of Recovering Together, which is my primary mentor, who's remote at MGH, developed for neuro ICU. And so, the benchmarks are rooted in that trial. I should also mention that I'm fortunate enough to have the mentorship of Carrie Levy and Lisa Brenner on this campus.
And we have about 5 minutes left if there was
5 minutes?
one additional question.
Perfect. So this is just the model and the components, which I will kind of spare, kind of recruitment strategies, which again, I think I have a different question. Sorry, I'm trying to, let me go back to recruitment. These are my strategies for recruiting dyads. I'm thinking about it from kind of a multiple sources of how to engage this population. So initially thinking of, residents getting self-referrals, I do not expect that I will get many, if any, self-referrals. And so I'm thinking about how do I minimize the burden of staff to actually identify folks for this study. So I'm thinking about really targeting whoever is doing those admission screens, kind of like the intake coordinator, just to give me a list, and then I can follow up with folks, assuming that I'll be in the SNF, using interdisciplinary team meetings, care plan meetings, just kind of trying to integrate myself as much as possible to get referrals. Now, the question is, like, getting the patients, the residents is, I have these multiple strategies to get to them. But then, this is a dyadic intervention. So, how do I then engage care partners? So I think one strategy is to think about, engaging the patient who then can contact their care partner. Another strategy would be to engage the care partner to then recruit their patient. And I think based off of my experience in SNFs, a care partner might actually be a little bit more enthusiastic about this. But, for anyone who's done work with dyads, I would love any feedback about, essentially just like caution, like warning signs, like any cautionary tales about how to recruit dyads in a medical setting when they're not going to be together. And I will stop my share because that's my final question.
For our LVAD project, we recruited dyads, and we got about 75% or so to agree, and didn't have too much trouble. I'm not initially really worried about it at all. I mean,
Where were they when they were being recruited?
In the ICU?
Yeah, see, that's the difference. We tried to recruit from a SNF and they were too busy. They had to go to therapy. They had to, do all the stuff while they were there. And so they were never really in one place for long enough to.
The caregivers weren't, or the patients?
No, the patients. Oh, you're referring to caregivers?
Yeah.
Got it. And the caregivers are often so busy too, because now they've got this extra problem. But go ahead, sorry.
Oh, no. So, and the dyad is caregiver and patient, right?
Yeah.
Yeah. No. Yeah, recruiting do you have to have a dyad for the intervention?
Yeah.
Okay. So I missed the first 7 minutes. Roger's dog thinks.
This is very exciting.
Yeah, Rod, you cut off. We were getting really good information there. So Dan, can I ask what do you think was the thing that was so engaging or so appealing to the dyad that you had such a high success rate with recruitment?
I don't know. Carrie may have nailed it. We had a pretty captive population that actually had a little bit of time. We would enroll. It was easier. We enrolled the patient. We didn't have to have a dyad for the trial. So we'd enroll the patient, and we had a very non-threatening question I forget how it was worded, but who is the person you would identify as the most involved in the caregiving, and would it be okay if we approached them? And so I think that probably helped. I think we probably stole that from Gene Kuttner or something, because somewhere in the PCRC, I don't know where, but we definitely stole that strategy from somebody. But I think that enrolling the patient and this non-threatening approach to the caregivers, we were pretty happy with how many caregivers we got. I mean, you're in such a different setting. I think it is a totally different ballgame, but I don't know. I don't know why it would be any harder than just recruiting the patients themselves, except that you need them both. So you'd have more exclusions, I mean, but it's probably hard to recruit the patients, but once you get the patients, the caregiver, getting that second step to the caregiver is not that hard. I mean, I wonder if there's any way you could recruit patients and not have them required to have a caregiver.
I've seen like more informal versus formal caregivers designated in some behavioral studies too. Like they wouldn't have to necessarily be like the medical power of attorney or the one true like go-to caregiver, but could be a little more flexible, someone else who maybe then has a little more time. Just another thought.
And I think with that, we'll go ahead and wrap up this section. Evan, thank you all. And there's great comments in the chat about finding, trusted care providers, and all kinds of good suggestions there. So any last thoughts, Evan, before we turn to Mustafa?
No, thank you so much. This has been really helpful, and I am looking forward to reading through the chat.
Yeah, and some great resources linked there too. Excellent. I think we could have spent an hour and a half on that. Okay, Mustafa, if you would like to go next, and then I'll check in with you in like 20 minutes to make sure we're making good progress on your slides. If you're speaking, we can't hear
sorry,
you. There you go. There you go.
So let me go back to my first slide. All right. Thank you very much. This is my honestly favorite audience to talk to. My name is Mustafa Ozkaynak. I'm a faculty member in College of Nursing at NuHoPS. And today I'd like to talk about a new initiative we try to develop within campus. So it's about nursing homes patient safety learning lab, and the initial acronym is NuHoPS L2. It's like Elon Musk's son's name. So the purpose here is to build a patient safety learning lab for nursing homes, and some characteristics of this project will be, we will be focusing on patient safety and some patient outcomes and staff outcomes concurrently. So both patient safety and the staff burden is our target outcomes. They are both our target outcomes. And we are envisioning a more safer care in nursing homes through using clinical decision support tools. And these tools will be in some sense novel because of two reasons. The one reason is the users of these CDS, clinical decision support tools, will be both, like not both, all residents, their proxies, and clinicians. So all these three groups will be the users of clinical decision support tools, and the data will be both coming from some sensors as well as EHR. So we also like to use implementation science as I'm about to discuss in next slides. And we will use system science principles and obviously it's not unique, but the multidisciplinary team is an important component of this initiative. And we started this initiative kind of inspired from a call, it's a AHRQ call. And this call entitled Patient Safety Learning Laboratories, Advancing Patient Safety Through Design, Systems Engineering, and Health Services Research. And one of our goals here is to, so this is R18, submit R18 proposal to respond this call. So here is an interesting terminology issue we are facing here. So the commonly accepted term is patient safety, but the term that to address the people living in nursing homes, they are called residents. So although a few people use the term resident safety as the term, but still patient safety is probably more commonly used term for the safety efforts in nursing homes, but I will sometimes might say resident safety as well. But typically, I'm going to use the term patient safety, although we know that the term for the people living there are the residents. So here is some important background information. So the patient safety efforts have primarily focused on improving safety in hospital and ambulatory settings. So the last 20 years, a lot of research, a lot of interventions developed, but they are typically focusing on hospital and ambulatory settings. And an important reality about the residents in nursing home are that they require, so they're disproportionately older and chronically ill, and they often enter long-term care after an acute admission. So this makes them even more vulnerable to patient safety issues in nursing homes. And there is some research that highlights that poor patient safety in nursing homes leads to avoidable emergency department visits, injuries, infections, hospitalizations, and increased mortality. But there's also some established links that poor patient safety also leads to increase in workload and burden on staff and the turnover in nursing homes. So we have 4 specific aims here. So the first aim is to identify and define work system redesign requirements in nursing homes to predict hazards, improve decision-making, and reduce staff burden. And second specific aim is to develop a CDS system, clinical decision support system, and associate tools to improve safety and quality of care and reduce staff burden in post-acute and long-term. And the third aim is to identify necessary intervention and context adaptations for the successful implementation of CDS in nursing homes. So that this is our D&I science related aim. And the fourth one is to develop a transdisciplinary patient safety learning lab aimed at engineering work system and improve decision-making and reduce staff burden in nursing homes. So these are our draft specific aims or aim options, aim alternatives we can use in our proposals. So I just want to talk a little bit about our third aim, which is more related to D&I community. So again, this aim was to identify necessary intervention and context adaptations for the successful implementation. So we are both interested in intervention and context adaptations. So for this purpose, we consider to conduct some implementation workshops. So these implementation workshops, they will include some hands-on activities with staff members, residents, and their proxies. So this again, the CDS will be used, the clinical decision support system will be used for all these three populations. So as expected, the workshops participants will include staff members, residents, and their proxies to identify necessary intervention and context adaptations. And then we will develop implementation guidelines for the success of CDS system. And we are thinking about 3 associated examiner CDS tools. So the one tool will be to predict falls, individualized prediction of falls for residents. And the second one is prediction of burden on the staff members. So the individualized prediction of burden on staff members. And the third one will be, it's a kind of a, very roughly we can say a checklist for transitions to ED and from ED. And again, we are aiming here improving quality of care as well as quality of work life. So these adaptations may include supplementary systematic work interventions such as other informational tools. So for example, these are, we are mostly focusing on context related adaptations. So how can we modify context to make sure our intervention will have most successful chance possibility. So again, our CDS may require some other informational tools or changes in the existing informational tools, may require some task redesign, so that maybe the tasks will be performed differently after the CDS we are proposing, and some policy changes also possible, like the rules to enable the full potential of CDS. And again, we want to make sure we do some context adaptations to ensure sustainability and build capacity for resilient performance in nursing homes. So this is the conceptual model we consider using. So it is SIPS 2.0. So the SIPS stands for Systems Engineering Initiative in Patient Safety. So the left part, which is the core of a SIPS model, so tools and technology, organization, persons, tasks, and internal environment. So these 5 components, they make up the work system. So I think these 5 components can guide the adaptation efforts. So basically adaptations to context. So when we think about adaptation to context, what do we mean by that? So maybe we can make changes or modifications to tools and technology, to tasks, person, organization, and internal environment. So this work system kind of helpful for us to operationalize context and develop adaptations. So again, this work system through processes affects some outcomes, and these outcomes lead to some adaptations, but this is coming from systems science. So this is a feedback adaptation in the sense of feedback mechanisms, but it's slightly different in D&I science adaptation. So we will also look at the adaptation in the D&I science sense that we are gonna revise these 5 components in the context to make the CDS used implementation as much as possible. So another interesting D&I issue that we can discuss today, if we have time, is that we consider nursing homes as the intersection of clinical settings and daily living settings. So that they are, to some extent, daily living settings, but they are also in some sense clinical settings. So the question here is that, can we consider nursing homes as laboratories to develop testing and implementing interventions for daily living environments? Because developing health-related interventions in daily living environments is very difficult. Can we use nursing homes as a laboratory, as a transition state, like the living laboratory, to develop interventions for daily living environments?
So Mustafa, did you want to start with this question, or how would you like to?
So actually, these are the questions. So let me finish my slide so that my real questions are at the end. So that these are more questions to ask ourselves, but we can also talk about these questions as well, if it's okay. Yeah. So the next step for our initiative is to create the team, and then being a part of the community, and submit proposals. So these are 3 steps ahead of us. So I like to thank you, the PACRES group, Post-Acute Care Research, and the Team Science in Anschluss. And I also like to thank Plys, Post-Acute and Long-Term Care Knowledge Network for Older Adults and Workforce Initiative. So that both these groups inspired me a lot to work in nursing homes and develop some meaningful interventions for nursing homes. And I also want to thank D&I graduate certificate faculty who gave me the DNA science ideas. And so these are my 3 main discussion questions here, actually. So what type of hands-on activities can be useful for a participatory session with participants to identify adaptations? So that's an approach we consider using. So I inspired this from the design workshops idea, which we do a lot in engineering. So these are implementation workshops. So the half day gatherings with hands-on activities to solve an implementation related problem, for example, develop or identify some adaptation needs. So this is my first question. Second question is, so the one unique, interesting, let's say not unique, but interesting characteristics of nursing homes, that they are very low resource settings compared to inpatient or outpatient settings. So what are the unique implementation challenges in low resource settings such as nursing homes? And my last question is how to overcome these challenges. So I think this is end of my presentation.
Mind going back to your question slides so we can have those in front of us? That would be great. Thanks.
This is Dan Matlock. I can jump in with a question. You know, as you were going through, one of the things that popped in my mind when you talked about the half-day workshop, you know, if I was a reviewer, was immediately starting to wonder, how are you going to convince people to come? How are you going to wrangle them? What incentives are you going to pay the nursing home to have them set aside this time? You know, when I reviewed for PCORI, they're very clear that we're not that applicants are not allowed to pay for any of the implementation delivery. So, they need like letters from the sites saying that we'll protect this time. Whereas the NIH, maybe with an R18, it's different. But I guess I was just curious because I'm immediately feeling a little skeptical that people come spend a half day, even though you've done this before in other design things. I think about these resource poor settings in nursing homes, and I worry about that. So that might be a comment, unless you've got maybe there's a really good strategy for it. But I thought I'd ask you what you were thinking about that.
I think it's a great point that needs to be addressed. So in terms of incentives, typically what we do in design workshops is that the schedule it in a way that like the provide other than providing food and drinks, keep people busy throughout half, like when I say half day, actually like we are talking about 4-hour workshops and with some reasonable breaks and with a good scheduling and keeping them busy. These are some of the approaches that I have seen and I have used in previous workshops, but obviously we need to discuss it more with the like the nursing home staff and see if it is feasible or it makes more sense to divide it more, the 2-hour or 3-hour more sessions. But the idea here is that to come together and be together long enough that we can do some hands-on activities together.
And Russ is commenting in the chat that he is a bit of a broken record. But to help with the first question, it would be helpful to visit dicemethods.org to look for different options for different conditions.
Oh.
dicemethods.org.
Mm-hmm.
Yeah, it's a website that Bethany and colleagues, several other people too, have been involved with to look at different options for different types of stakeholder engagement things, given different requirements, how much time, how much money, what are your goals, resources there. But I just wanted to maybe start off the discussion on this, Mustafa, with a bit asking you a question, or maybe a bit of a challenge, or to be provocative. Do you know that like one session is going to get you what you want or be ideal? As opposed to, and again, I know this goes in the face of what Dan just said about getting people at all there, but I wonder, some of the best work I've seen done is by a group of, let's say, stakeholders, however you want to define them there, or your participants, kind of over time and kind of iterate things. Maybe the classic example, and I think, you probably talked with Meredith Fort about her work with participatory systems dynamic modeling and things even. I mean, that'd be a high level thing that you know tons more about than I do. But the notion about trying something out, seeing how it might work, whether that was, estimated in a model or actually with some data over time, or the more traditional implementation science things would be something like implementation or intervention mapping and things, but usually those things are more longitudinal, rather than just a one-time thing. So I know I'll stop there. Certainly, pros and cons of any approach, but I think it's a great question. I'd love to hear what others have to say.
So I'll just start, but as you said, different options, they have their own pluses and minuses. So the first of all, I think I see the value of being more iterative. So have some workshops first and then get some adaptation ideas and see how they work and then have another adaptation workshops. So the so having so the probably it's a better idea to so the depending on our proposal and our what we are going to propose, but I feel like the ideal thing would be to do some of the workshops first and then the second set, another set then later, but it is going to require more resources and more time. But given the dance command, so instead of having the half day one-time workshop, it might be better idea having 2-hour workshops with multiple people, let's say 6 2-hour workshops, and then come up with some adaptation ideas, apply it, and then to do another 6 workshops, not necessarily with the same people, let's say 6 months later, and look at the new adaptation ideas might be the more optimal design when I am thinking. But again, this is gonna be more resourceful in many sense, but it really depends what you propose, scope, and the objective of the specific proposal. But I wonder what other things as well.
I was just reflecting on Catherine's comment, which you may not, I can never see the chat well, Mustafa, when I'm sharing slides, but Catherine noted a challenge is lack of support from leadership to provide time or resources for staff to do the work. And you had noted right there, these are low resource settings. Maybe that's a similar issue. And it made me think about, before you go through a process with multi-hour workshops that would lead to recommendations on things that might take more time or more resource, you need to have some guardrails on the proposed changes that leaders would endorse. Like, well, if it's going to take more than X amount of time or X amount of money, like, that's no. Or do you need to do something first to try to engage the leaders to want to free up some time or resource so that you don't go through a great process of brainstorming and visioning, but it's all doomed because the leaders won't, you didn't follow any guardrails they might have put to it.
And this is Kathy, and I think the one other thing that we've also kind of, from just talking to a lot of the staff, is like, what does leadership support look like in a particular environment? Because sometimes when you get right down to it, it isn't always, time off or, I don't know, extra pay or something like that. It could just be, just endorsing it, just hearing that it's an important priority. I mean, it varies, obviously, and they need time off to be able to attend the sessions, but sometimes it's not as monumental as you think or anticipate it being.
And one of the things that keeps coming to my mind are the resident councils that are already happening. They're already getting residents together to do X, Y, or Z. There's already activities that are happening. Could this be integrated into the activities that are already happening? And those obviously will include staff as well. So can you be a little bit flexible in who's participating and what kind of sort of activity it is? But they have to do activities. They have to have a resident council. They will be coming together for those things. And so if you can build it into existing and required activities, it ends up being a win-win. There was another comment. Oh yeah, the guardrails concept being really helpful. Yes, and then one challenge we've heard when implementing an initiative is lack of support from leadership. Right. Okay, that's what we were yeah. No question about that. If the leaders are not on board, you're dead in the water. And are any folks here working in what would be considered low resource settings, or are you aware of references or helpful guides? I've seen a few things about working in countries, countries that are under-resourced, but I haven't seen healthcare settings specifically called out. Are you all aware of specific resources there? I see something from Amy about driving, but I don't think that's related to the current topic.
Low resources is such a important part that should be taken into consideration, that we have a editorial like with me and Carrie and another scholar that says how innovation can make things worse in nursing homes, because if any intervention is going to bring even a little bit more additional work on staff, it's gonna just make things even worse.
Yeah, the title of the article is Sabotage, Safety or Sabotage with Adding Research to a Long-Term Care Facility. So our proposal is you have to assess the organizational strain. And if the facility is too strained, you actually could make care worse by trying to introduce an intervention. And then it's in those cases, probably needs to be an overhaul and a redesign, not just adding a intervention. And if there's not literature on these settings that are struggling already, that might be a thread for this group to start bringing into the work.
Carrie, I was having a little trouble hearing you because of the mask, I'm sure. I kind of coming and going there. But did others might want to follow up on that or chat. But I did have a question going back, Mustafa, the figure that you had, I really liked about kind of the three parts there. Yeah, that one. And I was just wondering about using it in kind of the work system. If you could maybe just talk a little bit more about that. And I was curious whether that's an established kind of model or you made that up, but I wonder about using that as a lens to think about. And I'm guessing in terms of the issues with the low resource settings, I'm guessing that there may be unique ones, but that a number of the really important ones may be widely shared actually across any type of setting, whether they're high or low resource. But I kind of always like to have the idea of having a model or a lens or something which to look at things. And I was just curious about this one. Could you say a little bit more about it?
So I think the first paper about this came in 2006. And I would say it is relatively common model in human factors engineering. And so basically, these 5 components, and I think the nice thing about this model is very generic. So these 5 components, which so the idea here is that we can understand context by looking at these 5 components, and that's gonna this guy like your data collection, data analysis, and the many things. And I find this model pretty robust. And it's definitely not something I came up with. This is a relatively well-established model in human factors engineering literature.
Mhm. Well, it's helpful. I am struck by a number of the similarities, to other D&I models that, I'm sure too, whether it be PRISM or CIFER or other things. Sometimes in these settings, I like to think about normalization process theory. EPIS, is used a lot, has a number of similarities. And, each of those, as you said before, have pros and cons. But I'm kind of curious about this one, and I particularly like the explicit, inclusion of. Guess you can't see what I'm circling with my cursor. The inclusion of tools and technologies.
So I mean, obviously every model has its weaknesses and the strengths and its own place. So I do like this model because I find very practical to use, and it's very relatively self-explanatory to look at, and also these connections, these lines. Actually, I like them to say, so the implementation of a tools and technology it needs to be connected to organization, connected to people who are using it, connected to the task, and connected to the internal environment.
Yep.
So if we install or implement a new technology, we should also modify them to ensure fit and sustainability. And then I like this balance thing here to looking at all five together. And I think the one component might be missing here, or the one weakness here, is that it is looking at tasks, people, etc., but it doesn't really include like the time or temporal issues, like that could be maybe added later. But in that, otherwise, I have used this model many times in my papers, and I find this model relatively easy to use as well, and also the very generic, like to study many different settings.
Mustafa, there's so much interest now, of course, in designing healthcare systems differently. And I love the engineering mindset that you're bringing to healthcare literature. There's absolutely more and more interest in that, and very few people who are skilled and can contribute to those.
And also I like to use this model for implementation science as well, because again, for our specific project, we are implementing a decision support system, which falls under tools and technology. But this model recommends that if we want this model, this technology or this decision support system to work, we need to like the adaptations when if we are going to do adaptations to context, these 4 things we might be looking at. Actually, these five things, I can say the other tools and technologies as well. So in that sense, I think it provides a good guidance to where to look at for adaptations.
And I think on that note, we should probably begin to wrap up. Final comments for Mustafa? Right, Mustafa, oh, go ahead, Evan, sorry.
I was going to say, I really like the idea of looking at unintended consequences too of this kind of work, especially, if you think of like the broader societal view of, nursing homes and frontline staff, as we increase efficiency, what does that mean for, those relationships and a workforce that could, go to, a fast food, like very regimented system and make the same amount of money. So I really like that you're thinking about that as well.
Thank you.
And Mustafa, there's another comment from Connie in the chat. She's currently working on a patient safety learning lab submission also, and decided to reach out to potential provider partners in defining what they see as what they needed help with and how to engage them. And this helped greatly in focusing their work.
Nice. So good luck, Connie. So probably you guys are ahead of us. So we are still working out to bring in the application.
Connie, how did you reach out to them just from a logistical standpoint?
We're part of a Northern New England Clinical Translational Research Center, and we have physicians who are sort of lead contacts out through Northern New England is Maine, New Hampshire, and Vermont. So we have those that we know would take the time to answer 1 or 2 direct questions from a colleague. So it was very simple, very informal. It wasn't like a big survey. It was just help us learn how we can best help you. And that kind of engagement also will help us with recruitment later on and getting letters of support. We know if we can organize ourselves around, what are the pain points or what is really motivating to work on if we can stay away from the topic of pain. So that reaching out is just extremely helpful in us understanding, well, what's the reality on the ground? What's the clinic actually experiencing? We're working with primary care. Same thing would be true for nursing homes. There's a tolerance for change and a welcoming of it. I've worked with some nursing homes that have been able to have the capacity for working on change ideas if it fits their environment. And they will tell you they are the best resource.
Yeah. That's really helpful. That's our vision with this this feature we're going to have on an app that will allow people to engage in research, and then we can outreach those folks. So hopefully that will be useful to lots of us. Great. Okay, well, I think we will go ahead then and wrap up now.
Thank you very much, everyone.
Yes,
as usual, it's very stimulating for me.
Indeed. Ross, any last comments from you?
No, just thank you to everybody, especially the presenters, for stimulating talk and generating nice questions for discussion. So this was fun. Just a reminder for you regular attendees, this group does not meet next week, but we do meet the 19th.
Great. Well, thank you, everyone. I hope you have a good afternoon. We really appreciate your wisdom and look forward to the next Disco session in a few months.
All right, we want music next time, though.
Yeah, I'm so sorry. Off my game.
All right.
And a disco ball. Okay.
All right, there you go.
Okay, take care all. Bye-bye.